Hello all, welcome to another meet of Stroke Support India. Thank you for being here, and of course thanks to others who will be seeing this later as well. And I am very happy to have Bruce Hetzeler here with us today. We have had Bruce, old members may recall, twice I believe over the last couple of years, talking of different issues pertaining to stroke. He's himself a stroke survivor, stroke warrior. Suffered a stroke almost about 10 years ago at the age of 62, a severe stroke. And I remember that he was in intensive rehab for quite some time. And he returned back to teaching for 8 years before retiring in 2019, besides practicing magic. That is his passion also. And interestingly, he's a professor of psychology and neuroscience. So with some background in relative disciplines also. And today we are going to talk about stroke and sleep related issues. So with that, I hand it over to you, Bruce. Take it further from here. And of course, we'll come back again later in the chat. Thank you, and over to you, Bruce.
Well, thank you, Hardeep. It's my pleasure to be here. And I have a PowerPoint presentation that I will now put on the screen. And hopefully everyone can see. Let's see, here we go. There we go.
See. Yeah, we can see
everyone
that.
See that? Okay, I'm going to begin with an overview of sleep and then talk about the impact that stroke has on sleep. So there's going to be a lot to talk about. So we'll talk about the stages of sleep, which can be very generally divided into REM sleep. That REM stands for rapid eye movement, and non-REM or NREM sleep. Those are the other 3 stages of sleep. And we'll deal with the way these sleep stages are recorded. It's by looking at 3 types of electrical activity: the EMG or electromyogram, that's muscle tension; EOG or electrooculogram, that's eye movements; and EEG or electroencephalogram, that is brain waves. Then we'll talk about why we sleep. You think it would be important? After all, we spend about 1/3 of our lives asleep. So if you live to be 75 years old, you'll have slept for roughly 25 years. Then we'll talk about insomnia, dysomnias, and parasomnias. And then we get to the impact on stroke, hypersomnia after stroke, and in general, sleep problems after stroke. And at any time, I am happy to answer any questions people may have. I will try not to talk too fast or too slow. I'll try to talk just right. We will see. So to begin with, as I said, we have to record electrical activity to determine the stages of sleep. And the electromyogram or EMG is recorded. That's muscle tone, and that's usually recorded with an electrode on the chin. And then there's electrooculogram or eye movements, and these are recorded by putting an electrode just lateral to each of the eyes. And then we have brain waves or electroencephalogram or EEG. If you are wide awake and alert, which hopefully you are all right now, then your brain produces beta waves. This is at the top of this slide. Beta waves are low amplitude, fast frequencies. And then when you're just getting drowsy just before sleep, or when you are relaxed with your eyes closed, you have alpha waves. Then in stage 1 sleep, the brain waves get a little slower. These are called theta waves. In stage 2, you get sleep spindles and what are called K complexes. Then finally, in stage 3, you begin to have delta waves. These are those large amplitude, the high, slower brain waves. And then finally, in stage 4 sleep, you have almost entirely delta waves. And here you are, all hooked up for a nice quiet night of sleep in a sleep laboratory. Hopefully you can see all the electrodes attached to the face and the head. So brain waves, muscle tone, eye movements, all being recorded. And that all goes to sort of a little ponytail behind you that's plugged into a board. And if you need to get up to go to the bathroom or something, you push a little button and someone comes into the sleep lab and unhooks that all, and then you're escorted to a restroom. You have to take all those wires with you. They don't unplug those from your face, then plug them from a little board on the wall. Then you return, get in bed, they're all plugged in to continue your night of sleep. This is an averaged night of sleep, lasting here about 8 hours. And the night begins on the far left. The W at the top stands for being awake. And then there's stage 1, stage 2, stage 3, and stage 4. So within an hour after sleep, you can see you're in stage 4. Then you go fairly quickly back up to stage 1. Stage 1 now is also called REM sleep, or rapid eye movement sleep. This was first discovered in the 1950s. Up until this time, no one had any idea that this type of sleep occurred. Now, there are a couple of things you can note from this figure. First, there are about 5 sleep cycles over the course of the evening. That is, you go from REM sleep down to stage 4 and then back up about 5 times. Each successive REM sleep period gets a little longer. The last REM stage of the night, which is seen on the far right here, can last up to an hour and a half. And you typically wake up during this REM cycle. You'll also notice that the deeper stages of sleep, stages 4 and 3, occur early in the night. So you go through about 2 episodes of stage 4, and then stage 4 vanishes. As the night progresses, stage 3 gets shorter, and then it vanishes. So finally, as you're nearing morning, you're just alternating between stages 1 and 2. We'll first talk about NREM or non-REM sleep. These will be stages 2, 3, and 4. Now, what you're thinking is not a mental void. You are thinking, but it's more like normal everyday thinking. It's not like dreaming. It resembles non-directed thought when you are awake. It's so-called quiet sleep because you have slow, regular breathing. Even though it's called quiet sleep, if you're going to snore, this typically happens during non-REM sleep. Somnambulism or sleepwalking occurs, enuresis or bedwetting occurs. Sleep talking, if you're going to talk in your sleep, that occurs during one of these stages. And so-called intense nightmares or night terrors occur, especially during the first stage 4 of the night. In non-REM sleep, that is stages 2, 3, and 4, but especially 3 and 4, the more delta waves you have, the more difficult it is to waken the person. Therefore, stage 4 is the deepest stage of sleep. And if the person is awakened during stage 4, they're typically very confused and groggy. Your brain seems to be resting, and we'll have more to say about that later. In REM sleep, or so-called active sleep, there's increased blood flow to the brain and increased oxygen consumption. This is called paradoxical sleep. It seems like a paradox in that the cerebral cortex has low voltage beta waves, so it seems like the cerebral cortex is wide awake. Also, your eyes are moving. That's how you get the term REM, for rapid eye movements. But remember that electrode that's on the chin? That shows no activity because your body is paralyzed. That is, you cannot move during REM sleep. That's useful because you cannot act out your dreams. Now, it is more difficult to awaken someone during during REM sleep than it is in stage 4, except by meaningful stimuli. For example, if you have a young baby in the house, a baby crying will easily awaken you from stage 4 sleep, but other rather normal things typically will not awaken you. When you are awakened during REM sleep, you seem alert and attentive. That's quite a contrast to what happens, you will recall, if you were awakened during non-REM sleep, when you're groggy and confused. This shows the amount of time you spend in REM and non-REM sleep over the course of a lifetime. On the far left, when you're first born, your first 2 weeks. You see you spend about an equal amount of time in REM sleep and non-REM sleep. And you spend about 16 hours a day sleeping. Although to the parents, it may not seem like that because you always seem to be awake when they're trying to sleep. And gradually over the course of the lifespan, the amount of time you spend decreases, especially the relative time in REM sleep. So by the time you get to be 70 or so, theoretically, you're spending about 7 to 8 hours in sleep. And we will return to that later. So why do we sleep? Well, we could talk about slow wave sleep, that is non-REM sleep, and REM sleep. Slow wave sleep seems to be essential for survival. It cleans the brain. It literally washes the brain. And we'll have more to say about that later. It reduces free radicals. Free radicals are compounds with unpaired electrons that try to steal electrons from other things and can create havoc, therefore. REM sleep, in contrast, promotes brain development. That's why you have so much when you are first born. It also facilitates learning and supports what's called REM rebound. If you are deprived of REM sleep and then allowed to sleep, you have more REM sleep than normal. That's called REM rebound. Now, in terms of memory storage, we have to distinguish between declarative and non-declarative memories. Declarative memories are memories that you can state, that you can talk about. Non-declarative memories are things you don't talk about, rather you demonstrate by doing them. For example, your knowledge that you can ride a bicycle and can say that you can ride a bicycle would be a declarative memory. But actually riding the bicycle would be a non-declarative memory. You demonstrate you know how to do it by actually riding it. Well, REM sleep facilitates the storage or consolidation of non-declarative memories, motor skills. Non-REM sleep facilitates the consolidation of declarative memories, things that you can say. Sleep is what we call the ultimate brainwasher. Recent research suggests that sleep's basic purpose is to clear the brain of toxic metabolic products. Fluid-filled channels in the brain expand during sleep and allow cerebrospinal fluid to literally wash over cells in the brain and remove unwanted compounds, unwanted waste products from the brain. And this mainly occurs during slow wave sleep, non-REM stages 3 and 4. Those stages seem to be especially important in serving a recuperative function. Ben Lin published a paper in 2017 showing that how much you sleep could affect your susceptibility to Alzheimer's disease. They examined 101 people, all with so-called normal thinking and memory skills, but thought to have a risk for developing Alzheimer's disease because they have a close relative with Alzheimer's disease. The subjects responded to survey questions about sleep quality and also gave cerebrospinal fluid samples. It turned out those with the worst sleep quality and demonstrated daytime sleepiness and more sleep problems were also the ones with more of the biological markers for Alzheimer's disease in their cerebrospinal fluid. So there was more evidence of amyloid beta protein and tau protein in their cerebrospinal fluid. Amyloid beta protein is an extracellular marker of Alzheimer's disease, while tau protein is an intracellular marker. Both of them are used to diagnose Alzheimer's disease. In the deepest stages of sleep, as I mentioned, the brain cleans itself out of plaque and other toxic materials that trigger Alzheimer's disease. And those people with the poor sleep quality, they were at higher risk of developing Alzheimer's disease because they had more of the tau and amyloid beta proteins. Insomnia. There are a number of different types of insomnia. First, there's pseudo-insomnia. These people think that they don't sleep. Actually, all they need is a good night in a sleep laboratory in which all the records are taken and shown to them that they really do sleep. Their problem seems to be that their dreams consist of laying in bed trying to sleep. So while they are asleep and dreaming, they're dreaming that they're not sleeping. Nocturnal myoclonus is also called restless leg syndrome. That's where you kick your legs at night, and that either can awaken you or your bed partner. Psychophysiological insomnia involves people that worry that they can't sleep, and the worry in turn keeps them from sleeping. So the more they worry, the more they don't sleep, and the more they don't sleep, the more they worry that they're not going to sleep. Psychopathological insomnia is insomnia that accompanies disorders like depression and anxiety. Then drug-induced insomnia is insomnia caused by taking a compound that keeps you from sleeping. Then there are dysomnias. These are disorders that cause trouble falling asleep or staying asleep. One of these is sleep apnea. A person with sleep apnea basically has trouble sleeping and breathing at the same time. In narcolepsy, a person will tend to fall asleep in times when other people might just get a little groggy. I encountered this problem with a faculty member at Lawrence University, which is where I taught for 43 years. When I was applying for the job at Lawrence University, I had to give a talk in a large lecture hall. And this faculty member came in and sat down in the front row, right in front of me. And within about 5 minutes of me beginning my talk, he was sound asleep, snoring. I thought, oh boy, am I that boring? I'm not going to get this job. Well, I later found out that he had narcolepsy. And there's toxin-induced sleep disorder. That's where some compound that you take, either voluntarily or involuntarily, keeps you from sleeping well. And sleep apnea, which I mentioned before, involves frequent periodic cessation of breathing while you're asleep. It's not a single disorder. There's obstructive sleep apnea, central, and complex sleep apnea. The most common type is obstructive sleep apnea, in which the throat collapses, blocking the airflow. This affects all ages and both sexes. It's made worse by drinking alcohol, because alcohol will relax the throat muscles, causing the throat to collapse. Most often treated with a face mask connected to a machine that provides continuous positive air pressure, a so-called CPAP machine. There are also parasomnias. These are disruptive sleep-related disorders. REM sleep behavior disorder, I will talk about more in just a minute. Somnambulism is sleepwalking. In sleep-related eating disorder, when a person is asleep, they will get up and go to the kitchen, get food, and eat it. Night terror, or pavor nocturnus, is a problem most often found in young children. In a night terror, the child will sit up in bed and be screaming with their eyes wide open. They're unconsolable. Turns out they are asleep, and they will cycle out of it. This typically occurs in the first stage 4 of sleep, and no treatment is typically necessary. They will eventually grow out of it. Incubus, I'll say a little more about later, but in incubus, which occurs in adults, the person has a feeling of stones on their chest and being unable to breathe, and they think that they're wide awake even though they're not. And of course, terrifying dreams, or as they suggest, dreams that terrify you. Okay. REM sleep behavior disorder. This is a neurological disorder in which the person does not become paralyzed during REM sleep and therefore can act out their dreams. Being paralyzed during REM sleep serves a protective function, keeps you from hurting yourself during sleep. A stroke in the brainstem can cause REM sleep behavior disorder. There was one case, for example, of a man with REM sleep behavior disorder who dreamt that he was a linebacker and he was trying to attack a running back. And what he did was get out of bed and run right into his dresser and hurt himself. This is an artist image of incubus or pressing devil. Again, the person thinks that or has a feeling of something on their chest and they're unable to move. Here's someone that's really tired, even though just finishing a night of sleep. People often have hypersomnia after stroke. Many stroke survivors experience fatigue and drowsiness during the initial phases of stroke recovery. Excessive sleeping after stroke can raise concerns for both the survivor and their loved ones. However, sleeping allows the body to rest and the brain to heal. It also helps the brain conserve more energy, which is essential during stroke recovery. Your brain typically uses about 20% of your total energy, and this percentage only increases as the brain attempts to heal itself after sustaining an injury, like a stroke. Therefore, getting sufficient rest is completely normal and important in order for the brain to regain energy and heal itself. Furthermore, studies have shown that sleep promotes neuroplasticity after a stroke. You might recall that neuroplasticity is the brain's ability to adapt and rewire itself, allowing healthy areas of the brain to take over after functions have been impacted by brain damage. Therefore, there are many other benefits of getting adequate sleep and stroke. For instance, studies state that quality sleep helps with learning and memory, which many stroke survivors attempt to do. Sleep also helps boost alertness and strengthen cognitive functions. Generally speaking, stroke survivors should listen to their bodies and sleep when they want and get as much sleep as they can, because a healing brain requires rest. Although sleep is crucial for recovery, many survivors struggle with becoming overly tired and may develop a condition known as excessive daytime sleepiness, or EDS. While the reported prevalence of EDS varies widely, anywhere between 18 and 72% of all stroke survivors may experience it. Excessive daytime sleepiness usually decreases after a few weeks. However, about 30% of stroke survivors may experience this for at least 6 months. Excessive sleepiness may interfere with stroke rehabilitation and recovery, as well as affect mood, relationships, and daily activities. What are the causes of excessive sleep after stroke? Some of the most common effects of stroke include motor difficulties such as hemiparesis, or weakness on one side of the body, where the brain cannot communicate with the affected muscles as efficiently as it did before the injury. Normal daily activities take more energy to complete. For example, some survivors may find themselves taking longer to get up, brush their teeth, and get dressed. These activities can take up enough energy that they desire to take a nap right after this, and that is normal, because again, it takes more energy than normal. Increased energy expenditure of normal daily activities is one of the most common causes of excessive sleepiness after brain injury. However, there are other factors that must be considered as well, such as the location of the injury and other secondary effects. If you have brain damage to areas of the brain involved in sleep and wakefulness, like the brainstem or hypothalamus, sleeping disorders can occur. Sometimes there are contributing factors that may need to be addressed, such as anxiety and depression. Depression is a common secondary effect of stroke, and symptoms may include excessive drowsiness or sleeping a lot. When survivors show signs of post-stroke hypersomnia, doctors may check to see if depression is an underlying cause and may prescribe antidepressants or recommend psychotherapy. I believe that I mentioned in a prior talk that an antidepressant is often recommended during the first year after a stroke, and that taking an antidepressant aids in stroke recovery. Sleep problems are highly prevalent following both ischemic and hemorrhagic stroke, affecting up to 78% of stroke patients. These problems include insomnia and sleep-related breathing disturbances, as well as daytime impairments associated with post-stroke fatigue. Sleep-related breathing disturbances, such as obstructive sleep apnea, are the most prevalent sleep disorders following stroke, and some form of sleep apnea may be present in as many as 50 to 70% of stroke survivors. Sleep apnea is a condition that causes an individual to repeatedly stop breathing, which can interfere with a regular night's sleep. Survivors with sleep apnea may experience headaches in the morning, fatigue, or mood swings. Multiple direct and indirect mechanisms may underlie stroke-related sleep disorders, including changes to endogenous circadian rhythms, medication-dependent influences on sleep, as well as increased daytime inactivity and napping. While sleep-related problems are commonly reported during the acute phase of stroke, there is also increased evidence of disordered sleep-wake problems in later, more chronic stages post-stroke. In a cross-sectional sample of patients assessed 1 to 15 years following first-ever stroke, self-reported sleep quality was found to be relatively consistent, regardless of time since stroke, whereas daytime sleepiness worsened with advanced time since stroke, that is, it was more prominent with a number of years after stroke. Such sleep-wake disruptions after stroke have in turn been linked with significant cognitive and attentional deficits, as well as adverse health and clinical outcomes. On June 29, 2022, the American Heart Association made an announcement that duration of sleep someone gets is now considered one of 8 life essentials for optimal heart and brain health. The list also includes diet, physical activity, blood pressure, blood sugar, blood cholesterol, body mass index, and nicotine exposure. The association recommends that adults get between 7 and 9 hours of sleep per day. Sleep helps our brain and body repair during the night so we can wake up feeling restored the next day. It promotes tissue growth and repair, muscle repair, and the release of hormones. Good quality and quantity of sleep is therefore crucial in stroke recovery. If you're experiencing chronic pain after stroke, know you're not alone. Many stroke survivors report dealing with pain regularly. Sleep is crucial for pain management. Lack of sleep can make pain worse, so it's important to establish good sleep habits to help deal with pain. One of the best ways to ensure you're getting enough sleep is to go to bed and wake up at the same time every day. Yes, even on weekends. After all, your stroke doesn't take time off on weekends, and neither should your sleep. For dealing with insomnia, stroke patients should prevent themselves from experiencing noise and light at night, should remain in quiet rooms at night. Finally, one recommended treatment for sleep problems is cognitive behavioral therapy. This can be applied to patients who need long-term management of chronic insomnia. Here are some tips for better sleep. 1, go to sleep at the same time each night and get up at the same time every morning, even on weekends. Make sure that your bedroom is quiet, dark, and relaxing, and at a comfortable temperature. It's better to be a bit cool at night rather than warm. Try to follow a routine to help you relax before sleep, like reading or listening to music. Turn off the TV and other screens at least an hour before bedtime. You also want to avoid large meals, caffeine, and alcohol before bedtime. People often assume that alcohol helps them sleep. It does not, and it promotes waking up in the middle of the night. So try to avoid alcohol. Don't take naps after 3 p.m. and don't take a nap longer than 20 minutes. Avoid nicotine completely. Nicotine does not do any part of the body any good at any time. Get regular exercise, but not within 2 to 3 hours of bedtime. And don't lie in bed awake. If you can't fall asleep after 20 minutes, do something calming until you feel music, like reading or listening to soft music. And that is the end of my talk, Ardeep.
Thank you very much, Bruce. Quite interesting and covered many angles. I'm sure it will be useful going forward as well. And we can open to questions to the participants. If anyone has any question at the moment, they can just unmute yourself and or put it in the chat, whatever they prefer. And if you like, Bruce, you can stop sharing your slides.
Okay, I will.
Yeah, there you are.
Well,
Bruce, I have a question.
yes.
Why did you say that don't sleep after 3 p.m.?
You don't want to take a nap after 3 p.m.
Why?
because that will interfere with your night's sleep. It will disrupt your regular sleep cycle.
Okay, got it. And could you explain a little bit more about narcolepsy?
Oh yes, narcolepsy is actually is a genetic condition. It's something in which there are a number of symptoms. One of which is that you fall asleep very easily. For example, if you're riding on a bus, you might fall asleep. Or people with narcolepsy have been known to fall asleep while they're scuba diving. There's another symptom that sometimes occurs in narcolepsy, and it's called cataplexy. In cataplexy, the REM sleep behavior paralysis interferes during the daytime. So a person will just fall to the floor like a sack of potatoes. And this is typically triggered by unexpected events or an increase in excitement. For example, if you have narcolepsy and you're just walking along and someone throws a frisbee at you and says, "Here, catch," and you look at it and you'll just fall down like a sack of potatoes. Or parents have been known to have cataplexy if they're spanking their children. Now, I'm not advocating spanking a child, but someone with narcolepsy that does so may well just fall to the ground like a sack of potatoes. But the main problem is that they fall asleep at times when a normal person would not fall asleep.
And it's involuntary, is it?
It's involuntary.
Okay.
And again, it is genetic. There is a
Oh.
breed of dogs that has been specially bred that has narcolepsy. And actually, I think they're Dobermans. So they
Oh,
may come growling at you or something, and if you go boo, they'll just fall to the ground. And
right.
okay,
Interesting. Interesting. Thank you.
yes.
There's a question in the chat from Shruti. How does exercise 2 to 3 hours before sleep influence the quality of sleep?
Oh, you do not want to exercise 2 to 3 hours before sleep. If
See, what I'm probably imagining is, for example, I undergo physiotherapy, let's say at about 7 o'clock for about an hour, or let's say at about 6 o'clock for about an hour, while my
Yes.
normal sleeping time is about 10 o'clock, or let's say about 9:30, 10ish. So I should not be doing physiotherapy latest by about 6. Is that how it should be?
Well, again, I am not a physician. I just know what the literature says. Because the main way, the main pharmacological way to overcome sleepiness is to exercise. So if you're tired and you exercise, that will wake you up. Now, as you're approaching sleep time, you don't want to exercise because that will get things going in your brain that may keep you from falling asleep when it's time to sleep.
Yes, okay, yep, yep. On the other hand, some people say, I may be wrong, but there's a other conception is that if you are tired, then you will sleep better. Do you have any?
Well, yeah, if you're tired, well, not if you wear yourself out from exercise. I mean, there's normal tiredness and there's exhaustion from exercise. Again, I'm not a physician. I'm
Right,
not a clinical psychologist. I'm reporting what the literature says.
correct. Yeah, yeah. So you need to bear those aspects in mind also.
Yes,
You talked about sleep apnea
yes.
also, Bruce. Do the studies indicate that frequently happens in the stroke affected? Do they need to be, let's say, sensitive to that it might be happening to them?
Well, the sleep apnea is a problem that many people have, not just those that have had a stroke. I myself have sleep apnea. I have a CPAP machine, and I had sleep apnea before I had a stroke. Now, I live in Appleton, Wisconsin, which is near Green Bay, Wisconsin. And Green Bay, Wisconsin has a football team called the Green Bay Packers. Now, about, I'm going to say 15 years ago, I'm not sure, but there was a football player on the Green Bay Packers named Reggie White. He was a defensive lineman, and he died from sleep apnea. And after that, a lot of people were tested for sleep apnea and got CPAP machines. My wife's two brothers both have sleep apnea and have CPAP machines, but they did not have strokes. So it's something that people, if they're unusually tired, or more usually their spouse or bed partner will notice that they stop breathing while they're asleep, will recommend that they get a sleep study. And if the bed partner suggests that, you should get a sleep study, that is, spend a night in a sleep laboratory to see if you do have sleep apnea, because it can be fatal.
Okay, so yes, one needs to as you said, get a sleep study done. And
Yes,
I think these are special clinics where you spend the night and they monitor the sleep patterns, right?
that is correct. There are a couple of them here in Appleton. I'm sure every large city has uh, sleep clinics.
Mm. No, there are some in Delhi that I'm aware of, and it is more and more people seem to be aware of it. And as you said, sometimes even without stroke,
Yes,
can suffer from these issues. We have a question from Amanda. It says, is it normal to always wake up very early after stroke? I mean, she cannot sleep for more than 5 hours since stroke. So what would you say is she's obviously not getting sufficient sleep.
she
She's
should be sleeping more, especially after a stroke. But I didn't talk about it, but different people have different sleep needs. Some people, well, it would really depend on how much she slept before her stroke. For example, if she only slept 5 hours a night before her stroke, then that may be all she's getting now. But for her brain to completely heal, she really should get 7 to 9 hours of sleep. Now, I will say, right after my stroke, I did not get that amount of sleep because initially after my stroke, I spent 2 weeks in the intensive care unit at the hospital. And unfortunately, the intensive care unit was right next to the helicopter landing pad. So whenever I would fall asleep, it seemed like a helicopter would land or take off and wake me up. So that didn't help me any.
yeah, I can imagine that. Yes, yes. But as you say, it is the existing pattern, the earlier pattern,
Yes,
which would be an indicator post-stroke, of how much sleep is sufficient. And of course, if one is having specific issues, like you mentioned some of the symptoms, then of course that needs to be checked out.
and also, I didn't mention this, but in general, again, this is in general, women need more sleep than men. So on the average, women sleep longer than men do.
Okay. Mhm. Mhm.
That's good to know. I have a question. So I usually sleep around now, which is like 9:30, and I wake up by like 6:30, which is good. I mean, I'm not. I'm pretty relaxed when I wake up, but I do wake up once or twice in the night every night, and it's not like. Also, I have diabetes, so it's even before the stroke, I was pretty much waking up once a night. Um, does um, does this have any effect, or is it just well, the need is to obviously go to the washroom and have a little bit of water? But just wanted to check in on this also that in the night we wake up so many times, right? So how does that work?
Well, yes, you do. It is normal to awaken in the night, either because you're thirsty or you need to use the bathroom. So that is perfectly normal. And then the key is to just do what you have to do and then go right back to bed. Don't turn the TV on. Don't look at your cell phone. Don't get something to eat unless you're really hungry for some reason. But you want to get up and use the bathroom or get some water if your throat is really dry. And then you just go right back to bed.
Yeah, I mean, there is absolutely like no disturbance, so it's very easy for me to go back to bed. It takes just a few seconds, but
Yes,
so that really helps. But yeah, I get thirsty and all that. So, but that I think is okay. I guess
Yeah.
if you're saying
But
it's
that's
okay
fine.
to wake
There's
up.
no problem. There is no problem with that. The slide I showed of an average night's sleep did not show any interruptions, but that was a theorized or idealized night of sleep. Normally people do awaken again, either, I don't know, they blow their nose or get some water or go to the bathroom. That is perfectly normal. The key is, again, don't look at your cell phone. Don't turn on the television. Don't read something, then just go right back to sleep.
Got it.
Right, yeah. I see any further questions? We are almost approaching 1 hour. Anyone else has any other thoughts or experiences or questions? Maybe they can unmute themselves and just speak up.
Yeah, I have a feedback about speech. After a good sleep, I feel, the speech is much more clear and does not take much effort for my husband who has aphasia. So when he's very tired, it's very difficult for him to say even one word at times. So I say you better take a break. You have to sleep for some time so that you rest your brain and you'll be able to feel comfortable. So that is what I have observed. Sleep is very, very essential.
Yes, thank you for sharing that. And that is true. Sleep is essential.
Yes. Thank you. Thank you for the wonderful session.
You're most welcome.
Yes, indeed. Sleep, as you have also put it out, Bruce, is very essential for brain recovery, even for people who are not stroke affected.
Yes.
To recuperate from their tensions, their dissipations during the day. And of course, all the more important for people affected. So thank you very much. I think we can close the meeting now. Thank you very much, Bruce, for all your efforts.
It was my pleasure. Thank you so much.
Very much appreciated. Stay well, and I'm closing the meet now.
Okay, thank you. Goodbye.
Thank you, everyone.
Thank you, Bruce. And thank you, Hardeep. Thank you so much.
Thank you. Thank you so much.
Everyone, take care. Okay, bye.
Bye.